health strategy team were concerned with providing information to support decision-making to improve the health of our population. So half of all premature years of life lost in Cambridgeshire and Peterborough are due to known risk factors, including behavioral and metabolic risk factors. So behavioral risk factor will include smoking, alcohol, diet, drug misuse, and these are most commonly cause of premature mortality and morbidity in Cambridgeshire and Peterborough. Metabolic risk factors include high blood pressure, so hypertension, high blood sugar, BMI, and cholesterol. And tackling known risk factors will increase the quality of life, as about a quarter of years lived with disability are potentially avoidable. So there are different indicators that measure premature mortality and morbidity. For example, years of life lost or years of, lived with disability, but there's also others such as healthy life expectancy or life expectancy. So healthy life expectancy measures how many years of life from birth you will live healthy. So if you treat this as a XY scatter and you imagine here the x-axis with the distance in miles and the y-axis with the healthy life expectancy in years. So the blue balls will be the male, the green will be the females. You can see here, if you were to jump in a car and drive around the Cambridgeshire and Peterborough area, you don't have to travel much or many miles to see that there is quite a big discrepancy and difference in healthy life expectancy. So as you can, so here there is the national average for England for females, which live healthily longer than males, which is this one. You can see how Cambridge is doing not relatively too bad with 73 and 76 for male and females, but you don't need to travel much. And again, within 50 miles, you can see that you will go below the national average. For example, in Peterborough, and also in the Fenlands with Wisbech, there are more than 10 years of difference. And Wisbech actually has, for males, less than 60 years of healthy, years. But there's many differences also within Cambridge. If you have a look, so again, the males are in blue, females are in green. You can see how, if you plot the healthy life expectancy versus deprivation, you can see how with increased deprivation, you have a lower life expectancy. So same is if you analyze life expectancy, and this was healthy life expectancy again, but you can see that is a similar trend. And this trend, unfortunately, is quite common in healthcare. You can see here, if we analyze inequalities in A&E for Cambridgeshire and Peterborough, you can see how over time, here we're analyzing the Cambridgeshire and Peterborough population. If you imagine that you split it in 5 quintals of deprivation, you can see how quintal 1, which is the least deprived, which is here the blue line, compared to quintal 5, which is the most deprived, you can see how is the most deprived quintal, which attends A&E more often. And this is the rate per 100,000. Just for curiosity, this you can see the peak during the COVID, the first COVID lockdown, but you can see how after this peak, this drop, the presentation resumed and this gap again widened. And this is, as you can see, looks like a textbook example of a socioeconomical gradient going from quintal 1 to 5. And again, if you were to analyze also some specific presentations, such as mental health related presentations, you can see the same trend. So again, quintal 5, which is the most deprived population, present more with mental health related presentations. It's not all types of mental health related presentations. As you can see here on the right, self-harm doesn't really show the same trend, but is a bit of a concerning picture. And it's, you can see it also in primary care. So if we now move on into immunization, you can see how for children between in the first 5 years of age, there are multiple vaccinations that need to take place. And I'm not saying that all the immunization will show some inequality, but there are quite a few that are raising some concerns. For example, here in the first year, rotavirus shows statistically significant, and again, there are a few percentage points of difference, and you can see how that the more deprived areas are having their kids vaccinated less than the others. And what you can do is also analyze this using the slope index of inequality, which is another measure of health inequality. And if you imagine here, for every immunization at a specific point, we have a dot here, and you can see how if you plot this over time for different types of immunization, the trend is worsening. So with time, this inequality seems widening. Again, most of this is statistically significant, so there are not major concerns. The point I'm trying to make is that definitely these are things we need to keep monitoring and start acting on it. So since we are still we are talking on immunization, it's probably a good idea to touch the subject of COVID-19 vaccine. It's a hot topic. You can see how, although hesitancy at a national level is quite low, so positive vaccine sentiment is up to 94%. It was quite lower earlier in the year. But there are some inequalities here in hesitancy. So especially if we analyze this by age, you can see how younger ages are more hesitant. And then increasing the age, you see less hesitancy. So the good news here is that the age groups that are more vulnerable to this disease are less hesitant. So at least that's a positive. If we analyze this by ethnicity, again, this is at national level, you can see that 44% of Black or Black British adults reported vaccine hesitancy, and you can see this is more than twice than other ethnicities. If we analyze this by deprivation, again, based on the index of multiple deprivation, you see that 1 in 6 adults from the most deprived areas is quite hesitant compared to areas which are least deprived. So now, staying into primary care. So these are, I'm going to show you in the next few slides a few examples of where there are some other inequalities. So, for example, the prevalence of obesity. So every dot in this chart is a GP practice in Cambridgeshire and Peterborough. If you plot again this against the deprivation, although this is not statistically significant, you can see how with increased deprivation, you have a higher obesity prevalence. If we check also by geography, although Cambridge is not doing too bad, you can see how the rural areas and some deprived areas in Peterborough are showing more obesity prevalence. And if you split this in quintals, you see that there is almost a 5% gap between the least and most deprived areas. And with obesity, you can see a correlation with diabetes, similar trend. With more deprived areas, there is a higher prevalence of diabetes. Again, this is not statistical significant data, but it's just to appreciate the trend, which is worsening with time. Similarly, with cancer, we see a similar effect. So if we analyze here, how many, so the uptake of bowel cancer screening, you see how more deprived areas accept the invitation for bowel cancer screening. So again, people with from least deprived areas are more likely to accept this invitation. I'm not saying this is the same for every type of screening. For example, cervical and breast cancer screening do not show inequality statistically, at least in our area. So these are the examples. But again, for some settings, this is something that is starting to be concerning, and we have to keep monitoring. Again, for hypertension, it's interesting to see that, for example, if you split the Cambridgeshire and Peterborough population in 5 quintals, you do not have any inequality statistically. However, the hypertension control does show a 7% percentage difference, which is statistically significant. So essentially, more deprived areas are less likely to keep this in check and to monitor this. So what can we do about it? So there are multiple interventions that can be taken. So taking the last example, for example, for the hypertension in the cardiovascular setting, some interventions can be done at the GP level, and the GP practices will be doing that by themselves, but also at the system level, there are various types of interventions that can take place. So a return of investment modeling tool found that the improved use of antihypertensive therapy was by far the most effective way in Cambridgeshire and Peterborough to prevent premature death from cardiovascular disease, compared to improved weight management services and NHS health checks. Measuring blood pressure as part of routine primary care and opportunistically in pharmacies and the secondary care has a role to play in identifying previously unknown hypertension. So case finding in deprived practices plays a big role. So, and you need to promote the use of self-monitoring amongst all patients with hypertension, and provision of BP monitors in deprived areas, because they might not have the means to buy one and monitor actively over time. So a recent pilot project in Cambridgeshire and Peterborough, which promoted home blood pressure monitoring combined with a medication review, found a significant improvement in practice level control of hypertension. So this is just a small example of what some type of intervention that can work. But again, different areas will need different interventions. So they might need more, we need more tailored intervention. So there is not one single silver bullet that will solve all the issues. And apart from these interventions at the GP level, there's in other interventions more at system level, but also at national level. And for example, research plays a big part in this. So for example, this is just one of the many ways that research can help. But so the biggest impact on inequalities in life expectancy GPs and healthcare leaders to reduce these inequalities. And the study will focus on inequalities between groups that differ on the basis of socio-economical status, gender, ethnicity, and other dimensions associated with discrimination. And so this was my last slide, and I think my time is up. So in conclusion, this is just showing some of the issues that we have in our local area, and try to point out that there are some interventions that can be done more locally or some more at system-wide level. And yeah, so that's it. So thanks. I would like to thank my team for the help with this analysis, and also John Ford, which is one of the researchers from the University of Cambridge, which used to work in our department for helping with this. And if you are interested in more reports on health inequality, you can visit the CCG website. And I think I'll stop there.
Thank you. So I'll roll straight on for you, Peter. So I'm afraid the bad news for most of us is that doesn't smoke or drink in excess, or doesn't lead a life that may lead to a lack of nourishment through the placenta. Pruning, neural pruning. So in a less stimulating environment, more is pruned away because the network of your brain isn't kind of as hardwired. But in a more stimulating environment, you tend to preserve more of your kind of future brain capacity. So there's just something about who you're born to, where you're born in the early years of your life and early adolescence that really is absolutely crucial. Now, the next phase of life is the kind of early adult years and into middle age. So middle age in a deprived community is probably around about 30 to 35. In a really well-off community, people would consider they're entering middle age in their late 40s to mid 50s. So there's something radically different about people's life experiences. And the way most of us in policy see this is that people make lifestyle choices. And how can we help people make lifestyle choices that mitigates the weathering effect of the lives they lead? Now, if you're in a community that's very challenged, you may be holding down 3 jobs in order to pay the bills, in a 0 hours, low waged economy, the whole fragility of whether you smoke, drink, feed your children healthy food, those may be choices that are way down. If you take an hour off your work to go and see a GP, you may lose your job. So those are the sort of trade-offs that people are making who live in much more challenged environments, is they can't make those kind of rational man decisions that public health so likes. So the idea is, we increase the cost of tobacco, and we know that less people smoke, but a lot of people still smoke, much less than they were, but a lot more people smoke in deprived communities, around about 20%, than the 7 or 8% that might smoke in less well-off, some more well-off communities. So it's very difficult to make decisions in your middle years if you are not supported by a benevolent environment. Michael Marmot is absolutely clear, as I think are Public Health England and Duncan Selby, that if we were going to do anything in particular to improve health inequalities, it's probably to provide good jobs and very decent housing and a basic minimum wage. So to get people away, so we're seeing this, aren't we, post-COVID-19, that societies that after the Second World War started looking after the most marginalized and the least well-off, quite a Victorian paternalistic view, that we then went into this era in the 80s and 90s where we started talking about people not being deserving of benefit or not being deserving of help, and unemployment benefit was called job seekers allowance because it was something about getting a job, and if you got a good enough job, you would have a good enough level of pay, and therefore the rest of your life would somehow sort itself out. So that proved not to be so good. You probably know that we got into a real problem in government where levels of pay were so low that we were having to top up with other benefits. So the state ends up taxing the well-off. Employers in a country like the UK, and it's very typical in Cambridge, that haven't invested in better working conditions, better use of machinery to support workforce, employ instead large numbers of very low-waged people. And because they can't reach that basic minimum standard of income, the state then came in and started putting a whole portfolio of benefits together to get people up to an income. So employers were paying less, tax was coming from different sources, I'll come back to that, and the state was then topping up that employment. So the government then decided that actually what it was going to do was to try and move away from that with universal benefit, unify benefits, and then put in through the national minimum wage and other maybe mechanisms we'll come to in the next 10 or 15 years, where employers paid more, the state paid less, and hopefully then people would have a more decent income. And hopefully through other rules, their quality of life would improve. One of the great things I think we've lost in middle years was that one of the great achievements after the Second World War, apart from the setting up of the NHS and apart from access to universal healthcare, was that we had the trade union movement. Now, as it happens, my first election I voted in was in 1979, and it was the era when trade unions really had a very difficult reputation. And most of my life, I kind of saw them as quite difficult and challenging organizations. Well, I have to say, in the last 15 years, it's become really clear to me that organizations through national action, through legislation, through pressure, and through support and organizations that can help the less influential working poor, if you like, are absolutely essential and an integral part of our society. So early years, how do we help people? Middle years, how do we reduce the weathering impact? And then help people lead better lives, better engage with society, greater voice in better jobs and more stable employment and better housing. Now, the later years, which is a lot of what Peter was talking about, is when that's the point at which all these things that have happened have now kind of worn you out. So smoking, drinking, stress, all associated with raised blood pressure, comfort eating, eating poor, high-fat foods associated with diabetes, for instance. But it's kind of a bit late then, isn't it? So what we're saying is, well, we've spent lots of years writing beautiful charts about you, and we've mapped your postcodes, we know where you are, and somehow, you know, we're going to tell you the story that you're breaking and it's getting worse and getting worse. And then once you're broken, we're going to tell your GP that they ought to measure the things that are broken so they can actually try and give you some medicines to mitigate and ameliorate what's already gone wrong. And I just think there's something dreadfully wrong in that analysis, that it should have started much earlier, and we should be thinking about how we avoid people getting into that situation in the first place. Now, if you look at what percentage of your health and of health inequalities is due to how much of your life expectancy. So a lot of what Peter was showing there was healthy life expectancy that is amenable to interventions from the health service. And the kind of consensus in my world of policy is about the NHS probably has about an 18% impact on your life expectancy through intervention. So the rest of it is all those other things I've talked about. So the idea that the NHS is this kind of great machine that can intervene is wrong. It's having a small effect late in your life. And what I always like about life expectancy and the sort of presentations you get in health inequalities is they rarely talk about things like cancer, because a lot of the people in the most unequal parts of society simply don't live long enough to get cancer. So cancer is much beloved of particularly prime ministers and particularly of the Conservative Party, I think, is because a lot of the people that they represent are in the older communities where cancer really is a big and common issue across a lot of them. But if you're living in a part of Cambridge, which is an incredibly unequal city, the chances are that your friends are dying of drug overdoses, car crashes, violence, just early heart attacks, and probably strokes. Now, let's look at this concept then. So the idea was that I trained as a GP in Cambridge and worked as a GP in Cambridge as well as a psychiatrist. And in the old days, we had this lovely idea that your GP was your family doctor. So when I trained, I would, amazingly, for someone of your generations, I guess, patients used to come and see me and discuss the fact they were thinking of becoming pregnant. And that just doesn't happen. You wouldn't dream of going to see your GP. If you could get to see a GP, you wouldn't dream of going to see your GP to discuss about becoming pregnant. You would seek advice from others, probably well-informed sources, and you would chat to your friends, family, but a lot of it would probably come from various different websites or social groups. Then when a baby was born when I trained, I would visit up to 5 times in the first few weeks. So it was routine that we do a minimum of 2 visits to every newborn baby. And at 2 months, I would give the first immunizations to that baby. And we would form an incredibly strong relationship with families because we'd been into the home, we'd seen them with a new child. And giving immunizations is a really traumatic event for both child and mother. And that sort of sharing that information, as Peter was saying, you know, we had a lot less vaccine skepticism in those days. Then that doesn't happen anymore. Okay, so GPs don't have that closeness, they don't visit routinely. They may give the first immunizations, or it may be one of the nurses in the practice. Then during the years when people are really making their decisions, so let's say, you know, we've gone through the respiratory era, so I used to see lots of kids with earache and sore throats. Again, now that's seen by other health professionals, not by your GP. And it's worth noting that in deprived communities, there are more nurses and less doctors. And in well-off communities, there are more doctors and less nurses. So people in challenged communities, particularly in Cambridge and Peterborough area, see a different sort of health professional. I'm not saying they're better or worse, but they are getting a different experience. But during the next few years, which is as you come up to the teenage years, family medicine doesn't do anything for you. You can learn to have unsafe sex, you can learn to smoke, you can learn to drink, you can learn whatever drugs are available on the street. You may even become a street level type of person working in the drug industry, or move into the sex worker industry, etc. But no one comes near you from primary care, and this idea that the GP knows you is a complete fallacy. The people who do know you during those years, of course, is education. So in the old days, schools used to have school nurses, they had health visitors, some of them, even in those days, would have mental health support workers. And education would see itself having a quite significant role in the kind of growth mindset agenda, in the social agenda. But now with this incredibly focused agenda and curriculum, a focus on tests and the ability, your need to achieve academically, a lot of that soft stuff has been lost. And in Cambridge, Peter may correct me, I believe they disbanded the health visiting for children service many years ago, and support services that go into school are very little. So during these formative years, there's actually really pretty awful support, even though people are probably from 9 o'clock in the morning till 3:30 in the afternoon, are in an ideal place to engage in what is health, what are the life choices I could make, and of course, how do I get a decent job? Now, if you live in North Cambridge in particular, some of the challenged communities there, I run a small charity where we fund children from very deprived backgrounds, challenged backgrounds, to develop through travel or leisure and sports opportunities. When I go to the schools and talk to them, most of them say to me that Cambridge has nothing to offer them. So here's this world-class city that coach loads of tourists come and park with their engines running, making the environment worse. Here's this fantastic university city with one of the top 5 universities in the world. Here's this amazing high-tech industry that's making making chips that are in all these phones and computers. Yet actually, for people that live in less well-off parts of the city, it is incredibly alien. So the university doesn't improve their education. The fact that there are these incredibly high-tech jobs doesn't improve their opportunities to work or their life chances. And in fact, many of them move out of the city and then commute in, working in jobs which are much more fragile, much less well paid and low skilled, and see their children don't see any reason to come into the centre of the city because it's an alien place to them, and their parents are increasingly moving out and finding it all very disjointed because they simply can't afford to live in this incredibly expensive place. Now, one of the worst things about health inequalities and access to care is that if you're in Cambridge and you live in the most deprived area, you're actually much more likely to be seen in the hospital as an emergency. So more of your cancer will be diagnosed in A&E, and there's roughly twice the rate. So from around 1,600 admissions per 100,000 patients to 3,200 admissions per 100,000 patients. There's 3,200 is from the more deprived community. Those admissions are most likely to be for pain in the chest or throat, most likely to be for abdominal pain, or most likely to be due to genitourinary causes or chronic airways disease related to smoking. So all of those are things that aren't crashingly urgent most of the time, and with good primary care could probably be dealt with in a community setting and investigated with a good diagnostic and treatment centre that was close to where people lived. So there's this thing of more people from poorer communities going to hospital and then being kind of chewed up in the system when they probably could have been seen elsewhere. But the complete scandal, though, is that if you look at what's called elective admissions, so this is the people who have hip or knee replacements, a planned type surgery, the consumption of resources for those procedures is actually from the most well-off areas. So the most well-off areas are seen more often in the hospital and are using more of the resources. And a few years ago, we had a big change to the NHS formula where we managed to get 14% of the funding for the NHS formula targeted at the most deprived communities, mainly in the northeast and the northwest of the United Kingdom, or England in particular. We then asked the University of Manchester to see whether that extra 14% had actually gone to the poorest communities. And sadly it hadn't. The extra 14% was actually used by those with the loudest voices and the sharpest elbows, who simply consumed more healthcare because there was more available, whilst those who were least well off found it the hardest to still engage. So I'll pause in a second, but I'm just trying to give you a picture that being in a challenged community, the medical things that can be intervened with late in your life aren't necessarily top of the pile for you. If you live that long, you've done pretty well. And if you've managed to survive the challenging job environment, and I remember once going to a traveller's site in Liverpool and seeing a mother there who said to me, every time someone comes and sees me and tells me about my 7 children, they tell me off I've had too many children and that they're really dreadful. I'm really dreadful for bringing them into this world in this awful place. But can I tell you, I'm really proud of the job I've done as a mother. They've all completed school. None of them have been arrested so far, and they haven't gone into crime. So the challenges that that mother faced and the way she had managed to bring up her 7 children are hugely different from those that we see in well-off middle-class families who may be struggling with home education at the moment. It's a very, very different environment. So if I was going to make some recommendations, it would be much more radical. We introduced things like smoking bans, crash helmets, seatbelt laws, taxes on sugar. Those work at a global level and have changed the kind of background mood music. But I think we should be funding general practice radically differently. GPs, remember, are self-employed, so we should be employing healthcare teams actually by the NHS for the NHS. We should be working across education. We should be thinking about the life stages as I've described it. And in particular, I'll finish by saying we should be seeing elderly people as an asset, not as a deficit. Their wisdom, skills they've got to offer people, and finding ways to engage them, to keep them independent, at home, and a valued member and contributor to communities would be absolutely crucial. So there is hope for the future, but I think it's a lot more than just charting and recording the inevitable decay and deterioration of people's health across their life courses. We need more of an activist movement that's going to make a real difference. So I'll stop there, Anya, but I hope that's given you a sense that this is something that really needs action.
Thank you so much. It's great to have the data and then put it kind of into a bigger context and have some personal stories as well. I mean, I say it's great, but it's also very depressing to hear those stories and stats of it, because it's not the prettiest picture at the moment. But thank you so much. It was really interesting to get both of your insights. We're going to have a couple of minutes break while people can start posting any questions they have in the chat, and I'm going to put up a second Menti if anyone has any thoughts to share on that. So we'll basically I will time it for 3 minutes, so that will be at 47. We'll start doing some questions and answers to give you a little break. But thank you very much.
Thank you.
think we're kind of getting a summary, a lot of what Steve kind of touched on at the end, which is great that that's what's being thought about.
It's the idea of cradle to grave, isn't it?
Yeah. I'll just stop share a minute. Sorry. Yeah, so I think we can move on to questions now. So that's given you a taste of what people are kind of thinking, if that gives you some more thoughts on what you'd like to do. So we've got a question from Alice, which I guess can be addressed at both of you. So what can the university be doing to reduce health inequalities in Cambridge or Cambridgeshire? And what can students be like pushing the university to do as part of that? What can their role be?
Shall I start?
Yes.
Or Peter, do you want to go? I don't mind.
So I could briefly say two things. So one, get educated, because education plays a big part. And again, as in one of this, I've shown in one of the slides, research plays a big role. So again, the University of Cambridge contributes to a lot of research, and so this could be two of the ways how universities can help.
So it's vital for us to remember that universities are essentially charities. And as charities, they have certain obligations to their local population. So when universities were set up, a lot of them had a really close, now Cambridge was set up, was it 800 years ago or something? I forgot what it is, but it's some, but most universities, particularly the red brick ones, when they were set up in industrial towns and cities, with the idea that somehow they would have engineering courses to support the mining industries, or they would, have science or arts or whatever. And Cambridge doesn't act like a charity. And it certainly doesn't act that its charitable status is maintained through its charitable actions in relation to people within the immediate geography of where it's based. So as one of the largest employers in the city, and quite a large employer of low-wage people in jobs such as porters or cleaners, whatever, I think it singularly fails to take on its charitable status. And worse than that is that charities are exempt from business rates. So 90% of a local government's income now comes from business rates. And if a university is largely exempt from business rates and it's a charity, it's getting an awful lot from Cambridge. But actually it's giving very, very little back to the people who are at the kind of bottom of the pile. In my charity, I tried doing some work with clusters. It turns out Cambridge colleges are in clusters, and the clusters are linked to schools. And so 2 or 3 colleges are generally linked to 4 or 5 schools. And I found it almost impossible to break through the bureaucracy because it doesn't work routinely. So wouldn't it be great if you as students could be routinely paired with groups of students? So you probably need to get to students not in their A-level year, it's kind of late. Why don't we find a system where you pair with, Michael Marmot used to say to me, the ideal time is probably 11, 12, 13, where people are starting to have aspirations and visions that are different from their family pattern. But remember, a lot of people, there's nothing wrong with wanting to be a porter like your dad was a porter, or wanting to be a cleaner like your dad was a cleaner, because a lot of kids are very proud of their parents. But it is something about going in as young people, as students, and saying, hey, there is this other place. It's not an alien place. It's somewhere I come from a background that isn't very well off. I'm at Cambridge University. How can I link with you and help you? So reaching out, acting like a good employer, starting to spend some of its huge money on making better links into the city, but just making it easy for you young folk to just get out there and just engage and inspire. You've got fantastic sports teams that should be out there. The rugby teams is what I was trying to do, was to get the rugby teams to train young girls at the age of 13 how to play rugby, because rugby for girls at 13 becomes a contact sport, and it's quite a big transition. So I think there's loads that can happen. Thank you for asking the question, but it's as much about political will, but I think someone needs to shame them at some point and threaten to take away this charitable status and make them pay the rates.
Yeah, thank you. Yeah, there definitely is a lot more that could be done. Sometimes the Cambridge bubble is just very much the university bubble rather than anyway the town it's in. So yeah, thank you. Leading on from there, Isabella has asked who else can kind of be involved in changing the people who feel most marginalised and are in the most deprived communities in Cambridge. How can we make them feel more engaged and more able to access healthcare and less like alienated from all those systems that they're currently just feel completely separate from? Who else should be playing a key role in that?
I think it's probably the people that live in the communities, isn't it? You know, the idea that people that live in impoverished environments don't have aspirations is complete rubbish. I had a big row with the Secretary of State, Patricia Hewitt, where she said, you know, we want to raise the aspirations of people in poor communities. I said, no, Patricia, you want to meet the aspirations of people that live in poor communities and give them a chance, because no one wants to be poor, no one wants to die early, no one wants to have a drug habit, you know. So I think we need to go and pay attention, listen, and help give voice to them. The second thing is the health service in the UK at the moment has a completely huge democratic deficit. So in the old days, you know, we had health authorities, 101 of them with boards. We had local GP practices with patient participation groups. We then gone through so many changes, but in the early days of what were called primary care trusts, we had lots of non-executive directors drawn from communities. We had Health Watch and various challenge groups associated with that. And I would go as a deputy chief executive at Bedfordshire and Luton. I would go to an overview and scrutiny committee or a health and wellbeing board. These are all local authority boards, probably every quarter, and I would have to justify what's going on. CCGs now that's completely gone. The integrated care systems don't have any boards. There's this, you know, local authorities who are still the voice of those people. So if we can go and listen to them and get them probably a bit stirred up and a bit angry, you know, to rightly demand more, it's mainly local authorities that connect with them. And I think the final thing I'd say is that I'd let them know what resources we spend on them. So at the moment, if you're a patient in a GP practice in Cambridge or Peterborough in a well-off area, your GP is being paid more significantly per head than if you were a patient registered in an impoverished practice. Now, if we switch that and said, I'm sorry, well-off GPs, you're going to have the budget of the less well-off GPs, and you know, vice versa, and then we went out to patients and said, did you know your GP's paid £142 a year just to register you? Are you getting £142 worth of value from your GP? I think most people would say, what? Who? I can't even get to see them. So, you know, let's give them a budget, let's give them some transparency and let them know that they're really getting a rotten old deal and help give them some voice. Peter, sorry, that was a bit political.
Yeah, thank you very much. We'll move on to a question for Peter instead. Peter, there's two questions which I'll just ask at the same time because we're a bit limited. Isabella has asked, do you know any other cities that have shown similar disparities to Cambridge and have like had some successful initiatives to close the gaps? And I guess Steve could come in briefly on that afterwards. And then also, do you know if there's any evidence on changes in the take-up of paediatric immunizations in the local area where coronavirus hesitancy has been an issue? Do you know like any comparisons with the trends there? It might make more sense to start with the second question actually on the vaccine.
The second one. Yes, so it's not easy really to make a direct comparison. So, and the problem with the data is that always there is a lag. So it's not easy to say whether at the moment this pandemic has changed the mindset for children immunization. So it's a little too early, I would say. What I can say, well, my gut feeling is that it wouldn't change much and actually could be exacerbated by the already issues that there are now, which are which depends from where a person gets their information. So how do you educate yourself, or how do you just get your opinions from? So obviously someone that reads a medical textbook will have, you know, a different opinion than someone that just Googles or picks up information from a social media blog. So I think this difference is getting wider, and education has a bit part of to play in this, I would say. And it's not a pandemic that will change it. Possibly will just again widen this difference. And so if I can go to the first question, if there are other cities like Cambridge with big gaps. So so it's a tricky question, because of course, as data analysts, we'll always find something to show and to pick up on. So they can always find some inequalities in something. So again, so as I've shown it with the bowel cancer screening, we do have some inequalities, but we are not doing too bad in breast and cervical, whereas other areas might be having this issue. The thing is that when Cambridge also gets is an example of inequality, is also because there is quite a gap. I'm not saying that other cities without a gap are doing necessarily better. So because Cambridge might be a bit polarized, having both the deprived areas and a larger and also a larger proportion of least deprived areas compared to other areas. So for example, although cities like Dundee, for example, might look less unequal, it's not because they're doing everything better than us, but it's just there is a proportion of the population which has less difference, I would say. So I'm picking Dundee just because I'm from there. So, but so again,
Peter, I could spot the Scottish accent. Yes.
But I don't know whether Dr. Fist has something else to add, or what is his idea on this.
I mean, I think it's quite an interesting question, because let's start off with the immunization one. You know, if you start reading, there's a really good public health director in London, Kevin Fenton, who was Obama's HIV advisor, and it speaks very wisely on a lot of this stuff. So look up Kevin Fenton. But what he and others seem to be saying is that the ingrained beliefs around immunization can go back generations in migrant communities. And if you know that your grandparents' generation was deliberately infected with venereal disease by doctors, or were sterilized, or were put into drug trials without their knowledge, or were sprayed with Agent Orange, you know, you don't kind of trust doctors in the way that you do, you know, in kind of middle-class leafy suburbia. And a lot of people that come to this country, particularly first-generation migrants that come to this country, may not have had primary care and may not have had preventative medicine, and may have had people in the village who were wise, or treated them with alternative medicines, as we would know. And if they really became unwell, they'd often walk many miles to a hospital, but they wouldn't know there was primary care. So to expect people in those communities to act in that kind of, I said, that rational man model, and to trust doctors and to find health in the way that we think they should, and be jolly grateful for it, I think is a you know, we just got to reset and go and listen and talk to people. In terms of the cities that improved, this used to be one of my watches when I was in government. You know, places like Sheffield have done extraordinary stuff in the past by using Peter's data and approach, going and saying to healthcare teams, actually, this is only 20 patients, or it's only 30 patients. We used to have these things for national teams called national support teams for health inequalities. And you can go into primary care and say, these are the 30 most risky people. And GPs don't mind dealing with 30 people. They get a bit scared when it's 80 or 100. So we can find good examples and share that practice. And I note a lot of the Cambridge and Peterborough papers do have evidence of good practice. And there is, what's it called, Peter? Your benchmarking data that you get from NHS Right Care. There's a whole lot of benchmark data. And in fact, Cambridge, in terms of healthcare, though we're the most unequal city, from the lowest to the highest. Actually, in terms of healthcare, we're the best of the 10 of our benchmark cities. So Cambridge is mitigating quite a lot of the impacts. The fun thing to remember on who's doing well is, I remember the people who did best in the country was Hammersmith. And we really couldn't work out why Hammersmith had completely overcome its problems of health inequalities. And it was because they built lots of flats that the middle classes have moved into. And all the poor people have gone off to Southwark or to Tower Hamlets. So, you know, the dilution effect and the geographical movement effects can completely drown out any good interventions that you're putting in. And I suspect that's part of what we see in Cambridge, you know, is Chesterton is becoming gentrified, isn't it, in a way that when I was a GP, you know, I used to lock my car doors in Chesterton. Now I walk by the river, you know, it's a completely different place.
Yeah, thank you. I thought maybe I'll just ask one slightly final question just to end on a slightly more hopeful note. I guess we were saying there that there are things we can see in other cities like Sheffield that are doing good things. But do either of you have any thoughts on looking further afield for lessons from what we could do better?
I think we should look internationally. I think there's an awful lot to learn from countries like Iran, Kenya, as to, you know, what we now call frugal medicine, but where people are using community networks. Instead of putting a £6 million MRI scanner in the local hospital, which diagnoses diseases we didn't know existed, and then have to find treatments for, how might we be a little bit more humble, look across the world at developing economies, as well as places like India, Bangladesh and others, and actually see where poverty is much more routine. Let's take India, routine scanning of the iris. You know, routine scanning of the iris is now giving people access, women in particular, to benefits, to healthcare. It's reducing the barriers. I think there's loads of things we could learn if we were just a bit more humble, as well as learning from our high-tech partners in the UK.
Yeah, thank you. I think that's something that I definitely read with the vaccine things around coronavirus. And definitely.
And it fits with your, you know, why are you an international healthcare group? Surely it must be so we go out and listen and learn. And the days of us going and telling people that the NHS is, you know, it's a fantastic model, but the Bismarckian model they've got in Germany with, you know, employers sharing some of the insurance costs, the way the Swedish, the very government funded rather than a minimum floor that we just kind of scrape people off, which has been the UK model, a much more universal, higher tax, more benevolent society. How could we learn from that? You know, the role of employers in people's health and development could be much greater, I think. Ongoing education, upskilling people, lots of really good stuff we can learn from elsewhere.
Yeah, thank you.
And by the way, I'm very optimistic. I genuinely think, you know, I think something is happening. I think your young people are fed up with this political system we've got at the moment, which is where international corporations seem to make more and more money, take more and more control, and buy out the competitors. So the devices we're using, and it's the same people now that it was 10 years ago, isn't it? You know, it's Apple, it's, you know, Amazon, it's whatever. I think your expectations of a more equal society, of a, you know, why did Jeremy Corbyn do so well for that period of time, was, I think, a great hope that someone might do things differently. And I just think be very noisy about that and organise yourselves to try and get something very different. We will all get old and stop voting sooner or later, so you will be the future.
Thank you. That was a really positive note. I know we've now gone past 9 o'clock, but there are still some more questions coming in. So I actually have to leave now, but I think the speaker said they would be okay to stay around. So I'm going to pass over to Rachel to field some of the more questions, if that's okay with Steve and Peter. Yeah. I'll pass on to her. But thank you so much for a great talk, and thank you everyone for joining.